Welcome to another episode of the Face podcast. Today, I'm very excited to share with you my episode with Melbourne-based plastic surgeon, Dr. Andrew Greensmith. I had seen much of Andrew's work come through my practice over the years that I've been in business in Melbourne, so I was very interested to interview him as I know he is an award-winning fine artist, painter, and he brings a creative depth to his surgical work. So if you are a fan of beauty, art, and plastic surgery, this is an episode not to be missed. I'm very happy to introduce you to Dr. Andrew Greensmith. I'm so happy to have you here as my guest today, Dr. Andrew Greensmith.
Thank you, Alex, for having me. It's a great pleasure to be here to share my love and passion for these crafts.
So lovely to finally meet you. Actually, I had quite a few patients with you over the years, so we do share some mutual patients for rhinoplasties in particular. I love the fact that you're actually an artist and, you know, blending the worlds of art, fine art and plastic surgery is just so interesting. But can you really sort of take me back to the beginning of how that all started for you?
Well, thank you for having me on the podcast and allowing me to share my love and passion for what I do, the crafts plural. I guess, a lot of people ask me as a surgeon how I started practicing as an artist as well. I now see the overlap, but I think I was always a kid with an artistic or craft type bent. And I think it's as simple as getting pleasure from making a mark, whether it be a blank piece of paper when you first pick up a crayon or a pencil as a child and you're fascinated by creating something from nothing. And I think that fed into, aesthetic surgery now, plastic surgery initially, making a change in front of your eyes. And for me, I was drawn into that when I happened to be at friends of my parents' house. This person was a surgeon, general surgeon, but he happened to have a book on the shelf in the library on cleft lip and palate surgery for children. Black and white pictures, and I remember being grabbed by that before and after change, the transformation. I knew nothing about surgery, plastic surgery. Didn't even know you needed to be a doctor at that stage to do it, which was a shame because I had to do medicine, right? So, but it drew me in at a very young age. I put it aside and it stayed with me. But at the same time, I seemed to be drawn to doing, my mother said I was often a difficult child, doing difficult things in that sense, or insisting on doing difficult things rather than simple things, but at a crafty level, painting toy soldiers, but not painting just a soldier, but putting a magnifying glass on and painting their eyes and their pupils.
So really the detail drew you in.
I think it was the detail and the touch, the tactile aspect of creating with your hands. And that thing of starting with nothing and then there was something, a line on a paper. That's all it needed to be to kickstart that creativity, I suppose, and that being drawn to creativity.
I worked recently with a makeup artist who I'd wanted to work with for a very, very long time, who I'd seen his work, and when I met him, he was only 23. This very, very tall islander, gorgeous guy, Con. And I said to him, how did you get into this? Yeah. And he was studying criminology, and during COVID, he started painting. Yeah. And his sister said, you know that if you can paint like that, you can do faces, right? Yeah. And he's now one of the most sought after makeup artists in the country. Yeah. Just incredible, the crossover.
Yeah, well, it comes back to that saying that a good art mentor of mine used to always say, that there's an artist in all of us waiting to get out. And many of us go through life and it never comes out. Not because we didn't try, maybe that's the case, but we didn't come across something that inspired us or someone that showed us that we could do it. Because I think we've all got the ability to do it. Assuming sound body and mind on a very fairly equal level, I think we've all got that capacity in us, which if you can tap into it, it's amazing.
So when you went to medical school, did you have the goal to become a plastic surgeon?
I did, which my classmates found very strange. How can you know what you want to do? And I didn't say to them, well, I've got to get over this hurdle of doing medicine to get there.
Not an easy thing.
Not an easy thing, but in the end I enjoyed that process. I really saw that there was, this old saying comes into play that, medicine is the oldest art form. And I could see that that was the case. And it's as simple as, you would know as a nurse working back in the days of working in general nursing, myself in medical school and then the public hospitals and general surgery. I mean, there's an art to breaking bad news. There's an art to talking about a cancer diagnosis to a patient. And we know that some people do that better than others.
They do.
And cultivate it. I think it can be cultivated in everyone, but you don't always get taught how to do it and tune into it. So.
I feel like I did so much, along the 3 years I was working in hospital, which led me to plastic surgery nursing.
Yeah.
And when I was working as a plastic surgery nurse, I felt this, oh my gosh, I finally have found what I love.
Yeah.
Like I loved seeing the transformation.
Yeah.
I loved seeing, the joy and the confidence it would bring to patients, So, I felt very at home with plastic surgery, which led me into aesthetics.
Yeah.
But fascinating that you already knew that before you began.
Yeah. Yeah, I think it comes back to making your mark. Satisfaction of what you've done is important to someone. We all need that. We all need to feel important in a way, to our parents, recognised, but making a mark that's important and change someone's life or enhance their life, I think that's what you've got that satisfaction from. That's where that feeling comes from. What
do you think one lesson you have learned about beauty or aesthetics over the years that you wish more people would know?
I guess that it's something that is a very individual thing to patients, and I think it should be treated that way. And I think that comes down to how we run, for example, consultations. The art of a consultation, that art word again, the art of, not saying it is art, but involving the patient in that, so they feel like they're involved in partly almost controlling the consultation or the process. And I think it reflects back on them feeling comfortable that you treat them as a person, as an individual. That's probably the biggest thing, rather than a cookie cutter approach. We may be trying to achieve the same light and shadow relationships in most people because we know those, our brain likes those. But the goal to get those in someone versus in one patient versus the other is different.
One of the things that struck me was grief. And I did speak to Brian about this when I interviewed him, but how much grief can affect aging.
Yeah.
So, people choosing to have plastic surgery procedures or enhancements because they've aged so much in the grieving process. Have you come across that?
I've definitely come across that, and patients have specifically said that they've been through this terrible process, death of a loved one, nursing someone, and that they now feel this is something they really need to do, and that's tied into it. And I think it's similar to stress. We know how much stress can age someone.
Absolutely.
Literally a year of stress can age you 10 years.
Totally.
We've all seen examples of that. So it's similar to that.
What procedures are you best known for, Andrew?
Well, you have to ask people out there what that is. I don't know.
Well, I know specifically that how I came to know you was your exceptional work with Rhinoplasty. So that is the first time I had heard of you, which would have been honestly 10 years ago.
Yeah. Well, it's interesting because my only website present currently, that's about to change, is for Rhinoplasty, and that's all I've ever needed to have. But in the background, I've plodded along doing a good amount of face neck rejuvenation, eyelid surgery, brow eyelid surgery, and a very controlled amount now of aesthetic breast surgery.
Okay.
And that's where I've stopped because I think that's plenty. And I think to become a subspecialist in those areas, you need to go deeply into them. And that's where I guess I feel like my patients come from, those 4 areas on a regular basis. But rhinoplasty would be subdivided into rhinoplasty primary, which as you become more in demand, you actually do less primary and more revision surgery.
Sure.
You actually become known for fixing noses, and unfortunately there are plenty of those to do. Yeah.
I want to touch on that a bit later because the medical tourism is such a massive conversation. But I want to also talk to you about, we're in 2025 and there are certain trends, even though plastic surgery has been around for so long, and we are still seeing the same procedures. What's exciting you at the moment in the industry?
That's a good question. I feel that it's probably in my sort of last 20, 22 years, it's the most exciting time to be involved in this. I think surgery, as a surgeon, I feel like surgery has never looked better as to where we're going with it. I like the way it's going, and it's that it comes from the rhinoplasty terminology. Preservation rhinoplasty has now cross-pollinated, and I'll talk about what that means in a second, to preservation facelift surgery, preservation breast surgery. So that word preservation, I think, speaks to an approach that's less destructive. That came from rhinoplasty about 7-8 years ago, where we came from a different angle to achieve a similar goal. We were dropping the noses back rather than taking the top off them. Now that's having its evolution, it's changing, it's morphing, it's not stayed the same as it was 5 years ago. We're finding problems, of course, and we're finding solutions to those. But I like the fact that we're using the term preservation and we're wanting to tread lightly. And we can talk later about legacy and the marks we leave in the long term on our patients. They're not always good. And we know that from 25 to 30 years ago.
Sure.
And we've responded to that. We responded to that with fillers, Botox, in response to a legacy of bad surgery or old-fashioned surgery. Now we're seeing a legacy of fillers and Botox, perhaps not Botox so much, but overuse of fillers.
Yes.
And surgery's responded to that. We've responded to that, and it's coming together in probably a nice collaboration. We're going to work out where each sits, what comes first, what should come first, what should come afterwards. But that preservation concept I'm really enjoying in rhinoplasty, in facelift surgery. For example, in facelift surgery, someone like my mentor, Brian Mendelsohn, who you've had on this podcast, who I respect a lot, he took us through that beautiful odyssey of an anatomical exploration. And we were separating layers of the face we'd never been to. We're probably now feeling like we don't need to separate all those layers.
Sure.
We can preserve some of them, go to some that he discovered, and that's all changing. We're preserving connections between tissues. So that's where there's that overlap, And for example, eyelid surgery, we're not taking fat out of eyes very much anymore because we recognise that maybe they look hollow and aged more so than if we didn't take the fat out. So we're moving the fat. Or we're supporting structures that have become lax. We're recognising that maybe it's not the eyelid, maybe it's often the brow. Why has the brow come down? Well, maybe the bone is resorbing, So we're addressing that, and brows are not being lifted so much. In my opinion, they shouldn't be. I call it brow modulation. I don't like the term brow lift because people are associating that with that surprised look.
They are.
But I tell them, I'm going to modulate your brow. I'm going to rebalance the muscles that are pulling them down versus those that are pulling your brow up so that you look natural, but your eyes are opened.
Can we just touch on that a little bit? Because, not our listeners aren't, usually in an operating room.
Of course.
I've been in an operating room with Brian Mendelsohn and, I can really say that for me, plastic surgery is the gold standard. And that these neuromodulators and fillers would complement and biostimulators.
Absolutely.
But I would really like you to talk about the difference between a coronal brow and a temporal brow and how that has changed over the years because it really has changed a lot, hasn't it?
Yeah. Well, you're exactly right. I think there's different procedures for different patients. There's still patients who will benefit from a coronal brow lift where you're making an incision right across the forehead. And we can apply that to certain patients.
So when you say forehead, you're talking right across the top?
The hairline, whether it's behind the hairline or at the hairline.
Sure.
Often what we're doing is coming further forward, which is paradoxical because it seems to the patient like it's more visible. But if we now look at our coronal brow lifts from 20 years ago, we're seeing hair loss on the incisions.
Much further back.
Yeah, much further back. We're also further from where we want to have an effect.
Okay.
So to be closer, we don't have to pull so much. So if we can be smart about it and put the incision closer, but perhaps at the hairline, but not make a straight line cut. If we zigzag our cut, we call that decaling. Fine little zigzags into digitating. A straight line is more visible on a bit of paper than a broken line.
Yes.
Right? So it's that concept from art again. How do we hide our tracks, but yet get a better result?
Sure.
Okay.
So talk about the endoscopic temporal lift.
Yeah, so I mostly do endoscopic brow lifts or brow modulations.
Sure.
It allows me to use very small incisions, and it allows me to get to an area low down on the forehead and modulate those muscles. All right.
Wow.
I'm quite happy to put those incisions close or even on the forehead because that area is a privileged area for healing. Scalp forehead incisions heal beautifully whether they're vertical or horizontal, and they can look like a tiny little almost invisible scar from a mole removal. Very obvious in the first few weeks, and you have to tell the patient it's going to look like that, but it enables it to achieve a goal without overly stretching or lifting the tissues. Yeah.
So when a patient comes in with an unrealistic goal, how do you handle that patient and respect their vision?
I think the key thing for me is imaging. For example, a vector system or otherwise, and some of these patients will show themselves as having unrealistic goals. They would have done their own imaging on Facetune, for example. That's not necessarily a bad thing.
Yep.
They may bring photographs in of celebrities. It's also not what we used to think a bad sign, always. It can be a bad sign. For some people, and many, it's just a way of communicating.
Sure.
People have become more visual because of social media.
Of course.
And we have to respect that and not just jump to a conclusion that they have body dysmorphia disorder. They may have it, but it's actually more rare than people say it is in aesthetic surgery. For most people, I find it's a way of verbalizing what they want, and that's great. Then I can tell them what they can have, okay? And I do that in a way that involves them in the process. They sit next to me with the imaging. They're not across the desk anymore.
Sure.
And I make them feel like they can move the imaging with my help, and then I can show them that they may want to take more off the bridge of their nose, for example, but I can say to them, well, let's settle on this as a good result. If you want me to take more, I'll make a note of it, but let's go at the time of surgery and make that final decision. But I want you to be happy with this. If you want more and you want a little bit more of a slope, maybe I can create it, but I won't promise it to them. And if they're not prepared to negotiate, then I know we've got a problem.
Okay.
Because all this is about trust and negotiation between two people. It's a conversation.
Absolutely.
It's a relationship, which is important. And all relationships are based on good communication, right? Otherwise, we're going to fail.
Absolutely.
And if they're not for me, you know what? I've always stuck to my guns on that. Possibly they'll find someone else who will book them the next day for surgery and do what they want. But that's a recipe for disaster, as we all know. Yeah.
So moving on to that, because it's such an interesting topic, body dysmorphic disorder.
Yeah.
So, you know, we do see quite a bit of it in the non-surgical arena, and patients come across the non-surgical sector, I find, with very unrealistic expectations because what they're seeing on social media is a surgical result, which cannot be achieved with a non-surgical treatment. I've had patients ask me a lot about Turkey. We're seeing it in the media. I've had a patient have a rhinoplasty in Turkey and returned home, had not mentioned that she was off to make, you know, such a big decision, and has not assimilated well back into her everyday life because she looks very, very different to how she looked before. Her friends and family, you know, are quite shocked, and the nose has been so overly reduced. And I've spoken to, you know, a colleague of mine, Jonathan Sykes, in LA about the same thing. Very well, and he spoke about it as well. But what are you seeing based in Melbourne from the surgical increase in tourism in Turkey?
Yeah, we can touch on that and talk a little bit about body dysmorphia and how that's changing in a different age group, which is really interesting. But I think probably the minority of patients are still daring to go overseas because it's a big decision. But I am seeing it. I'm probably seeing 2 to 3 patients a month, and I saw one this morning, for example, a young female who's psychologically disturbed by what she's got. She was convinced that that's what she wanted and what was going to look good. She was taken in by the social media of the surgeon. And I must say that most of these surgeons are excellent surgeons.
Sure.
I'm not seeing many technical failures. I'm seeing aesthetic failures,
So
bad choices.
Okay, so the surgeons are highly qualified.
I think most of them are.
And their technique is good.
Yeah. I mean, I have good relationship with many surgeons in Istanbul. I stay with one of them regularly.
Sure.
And I respect their work. I don't think these patients are always going to those surgeons. Perhaps they're a little bit more expensive than the one down the road in Istanbul. And I think most people are going for cost reasons. Most people.
Sure.
Some are just simply taken in by the social media.
So if the surgeons are highly qualified and their technique is excellent, where's the disconnect?
I think most of these surgeons, I can tell the work is good. They've respected the soft tissues. They haven't caused damage. They've created a shape on a patient's face that is inherently changing their sense of self, and the patient only discovers that afterwards. So there's a disconnect of aesthetics, of respecting someone's ethnicity and what will look good on a face. Unfortunately, it's often a cookie cutter approach. Excellent technical approach after excellent technical approach on all those patients, but it's the same nose. And we don't need one nose on 50 patients. We need 50 different noses, really.
Yes.
Of course, they might have things in common, those noses, and that's true. A relationship that's good between light and shadow. But we don't see that when these aesthetic choices are made badly, and that's where they're going wrong.
They are also really doing, what people make term the fox eye, which is that endoscopic brow lift where the eye is pulled very tightly. Are you seeing that as also?
I think I don't see those patients. I haven't. I've had some patients request it and I refuse to do it. I think that operation is completely wrong. And most of us, when we see it, we know it innately that it's wrong. Maybe we're not prepared to say it to the patient or to a friend who's had it done. The patient knows it. In their heart of hearts, they know it's wrong. And eventually they get into trouble psychologically because of it.
I saw Dr. Rod Roderick. He has the plastic surgery channel, and he posted a clip quite recently of a male patient that had that done overseas, and it just didn't look right at all.
No.
And the documenting of his process had been over a 12-month period, but even at the 12-month mark, he just did not look quite right. Is that kind of what you mean by there's a disconnect with aesthetic choice?
Correct.
Yes.
Exactly that, And I think that's very dangerous because beyond just not looking right, I'm seeing patients who are so psychologically triggered that they're nearly suicidal 6 weeks after surgery. And that's where I'm concerned. And I think we've got a responsibility to promote the fact that for that reason people need to be extremely careful about anything that is a radical change on any body part. I think can be quite concerning, and we've got to tread very carefully.
Because when they go to the mirror, they're not seeing themselves.
They're gone. That's not there anymore. And their brain, whether they like it or not, they can't help it. Their brain is giving them an incredible feedback. It's often associated with intense anxiety, including physical symptoms from severe anxiety, sweating, palpitations, rashes, those sort of things, and suicidal ideation. So their families, you can imagine, are completely beside themselves.
Well, they would be, because they would have been beside themselves before they went off for surgery.
And they've spent, they've perhaps got a cheaper price, but they've still spent a lot of money, travel. It's been a commitment, time off work, and now they've got to face the world feeling incredibly uncomfortable with themselves, with someone they don't know anymore.
Which is permanent.
Yeah, which is permanent. I mean, I can't take them back to what they were.
No.
Okay, I can make them a good nose if they have a bad nose, but I can't restore their original nose. There's no question about that.
Especially if it's been over-reduced.
Correct, yeah.
Sure. Yeah. So I'd like to touch on the rhinoplasty.
Yeah.
That is one of your signature procedures. What are people mainly coming in for? Straightening or bumps or reducing? Talk us through that.
Look, I think most people, if we take a group of 100 patients, 80% are coming in with what they call a hump or a bump on the nose. A small group of those have some significant asymmetry or post-trauma deformity or simply congenital deviation of their nose. I find a large proportion are complaining about airway issues.
Okay.
Or when I stress the airway in the consultation and reveal left and right sided differences, I can tell them that if they want to make the aesthetic changes, we have to address the internal anatomy of a septum, otherwise will reveal a functional problem
Okay.
that they may not have discovered until they were in their 40s, if they're in their 20s, because I explained to them the nose is a series of ligaments and joints. It's very complex. We're only discovering anatomy of a nose through the work in Russia that's coming out, the anatomical research by Peter Palsali, that's showing us ligaments and joints that we didn't even know existed. And so ligaments and joints, as we know, women who have kids, it deteriorates, right? All of us, men,
Absolutely.
women, it gets looser, it's not as strong. So I also have to go through that process of saying, well, if they want refinement and reduction, we have to do that in a way that strengthens their nose if it's becoming smaller or more refined, not weakens it like older techniques from the 80s and 90s. And there's an art to doing that.
Well, the nose is also aging.
Correct?
Yes.
Yeah, and so with the airway ages. And so an airway that's a sitter for a problem with a rhinoplasty, if we didn't do the rhinoplasty, will probably deteriorate into their 40s and 50s and 60s. They might start snoring, partly because of their airway or for other reasons, you know, to do with throat shape or jaw size and things like that.
So when you're meeting a patient for the first time and you're assessing them, are you making suggestions or do you wait to see what they are wanting to see you for?
I always put it over to them first, and I find that most people coming to me, they've already seen my work on Instagram or whatever, my website, and so they're attracted to my work, and they say that's because it's more natural. They still feel like they got to look like themselves, but I still put it to them as to tell me what bothers you about your nose. And some patients will say, no, you tell me how you can make my nose better, and I don't like that. I want it to come from them, and I say, look, feel comfortable to use non-rhinoplasty language. Show me a picture. Give me an idea of what's going to concern you, what you don't like. Sometimes tell me what you like about your face or your nose, you know. There's got to be something you like about it. If you just say, I hate my nose, the whole thing, then I feel like they're often being too hard on themselves. I actually like all the noses that I change. And I tell patients that. I like every nose. I mean, I get to meet 60 to 80 new people a week. Every one of those people that come to see me knows something that I don't know. And I'm fascinated to hear it from them.
I love that.
So it's a relationship that's really important. So get them involved and get them to speak about what they like about their nose, because it cannot be that their whole nose is horrible or ugly. I don't accept that. So I think that makes them more comfortable, you know, straight away with a consultation. And then they can open up to me and I can tell them, you know what, let me take you through what I think can be done, and I'll make some suggestions based on what you've said. And I might get you to try and change some things, and we can image that and see how you feel about it.
I love the fact that you're really embracing and encouraging the, you know, individuality of the patients, because it's, you know, I love that, you know, being authentic is so special, and embracing our imperfections is also, you know, something you probably get better at as you get older. But do you think your definition of beauty has changed since when you started your career in plastic surgery?
I think it has. I think it's always been something I felt as an individual, but perhaps art has taught me that imperfection is beautiful.
It is.
And then I'll point out imperfections and asymmetries to patients, and I'll say, let's embrace that. Because it's not going to change with surgery. It'll be a different sort of, perhaps it'll be improved symmetry, but it won't be perfect. But doesn't that just make us human? Otherwise we know when we look at an AI image of a human being, we can all tell that something is off.
Absolutely.
Because our brain is not tuned to perfect symmetry. And there's been some work done in Scotland with a unit there that does computer averaging of faces. It's called the Face Project. You can actually plug your face photograph in there and you can mix it with other faces. And it's incredible what you can come up with 20 faces mixed with asymmetries and all sorts of different combinations. But it just shows you there's a kaleidoscope of beauty out there that we should respect.
I love talking about asymmetry because it's the number one thing I hear from pretty much every patient that sits in my treatment chair. One of my lips is straight, the other one's curved, and you know I have to go through that with each and every one of them. When I had Brian Mendelsohn on the podcast, he speaks about, you know, the bony orbit of the skull and how one actually sits sort of in front of the other. And do you discuss that at length?
I do. I also do some education on the benefits of asymmetry. Let's embrace it, but on the proviso that they understand, unfortunately, that the smartphones we're living with multiplies that asymmetry. Unless you're more than 6 feet away, and this is work that my esteemed colleague Peter Callan's done, he's the only person in the world to do this.
Really?
And that's ground-shaking work that he published this paper to do with the distortion of a smartphone and various lenses. And that was game-changing because we knew what was going on, but he's quantified it. So unless you're 6 feet away, exactly, he's far more clever than me.
He's so clever.
He makes me feel inadequate, Peter. So, and I'm glad you had him on the podcast.
He's so great.
But, you know, telling patients that you get this model, for every, I think it's something like every foot within your face distance, there's 7 or 8% distortion, widening the nose, more droopy, and asymmetry. Your nose can actually look bent when it's not. And I'll get patients coming and ringing a year after rhinoplasty saying, I've got this bend in my nose. And I say, but haven't you seen the pictures we took in my office? It's straight. And so then I have to remind them that they're getting this bend because their face is off center and the smartphone is turning it. So I always say that my result's not going to be as good on your smartphone, unfortunately, unless you have 7-foot-long arms.
That is so fascinating. Yeah. So we actually look worse.
Well, absolutely we do. So that's why you've always got filters, right, to correct that.
Yeah, we do.
But you may still have to do some work with filters if you really want it to look better.
Yeah,
but
sure.
Nothing is like seeing you in person, and we can't see ourselves in person, right? How can we?
I love the fact that you encourage the individuality.
Yeah,
I really do.
It's important. It's essential. Yeah.
And I think that's sort of what happened, you know, with the volumizing treatments, because it was so cookie cutter, and all of a sudden these 22-year-old women, because they were getting their cheeks done and their chins done and their lips done, they all started looking the same and all started looking 35 overnight. And everyone kind of had this look from, it was around 2018 where it was just not a good thing. So thankfully, you know, with dissolving and, you know, hyaluronidase, we can sort of reverse that.
I think with the lens of retrospect, we can look at things differently. I think we talked about the excitement of the preservation era. I think on that subject, something that doesn't excite me so much is prejuvenation, as they call it, which is really upselling aesthetic treatments to young people. And I think we've all got to say, hold on, put a pause there. We have a responsibility to change that conversation before it gets out of control. Honestly, 20-year-olds, 25-year-olds, 30-year-olds, 40-year-olds, enjoy being young. Don't do anything to yourself. Maybe start to do some conservative fillers, some Botox, but don't react to your first wrinkle. Embrace it, because it's a storyline. It's not a wrinkle. I love wrinkles. I'm a plastic surgeon. I love wrinkles.
I think I definitely denied my wrinkles.
Yeah, sure.
I mean, I started in this industry when I was 23, 24. So I didn't have any volumizing treatments until I was 35. But I was definitely using neuromodulators. I was at an educational event for Allergan recently, and they invited a cosmetic physician from Poland, and she had collated all of her patients over the last 25 years who had only done neuromodulators. And I think it is an undervalued treatment. I think it can really, you know, it can work well for the skin and the skin quality.
Sure. Yeah.
But again, I think moderation is the key to life, and there is definitely not a necessity to start any kind of volumizing treatments before you need them. But I want to talk about bony reabsorption because I find it absolutely fascinating. What is going on for a patient? Because we talk a lot about jowls in a non-surgical setting, and obviously you do facelifts. So how do you explain that to a patient? What's going on in that aging process and with the bone starts to shrink?
I think it's not just the bone. I think there's a factor to that, and that varies between individuals. I think we're also seeing, in combination with that, and perhaps more so, some fat loss. But that combination of lack of bony support, fat loss, leads to the appearance of excess skin. I certainly don't believe we have excess skin with aging, not even perhaps on the eyelid. I think that tends to be more bony resorption of the forehead, brow descent, and the eyelid acts like a Roman blind, pivoting on the crease. Now, that means that we're often, if we're just doing an eyelid procedure, we're taking out too much skin, you know, more than we need to take out. If you do that on a patient who actually needs a brow lift, in combination or instead of an eyelid procedure, well, they can never have the brow lift done because they won't be able to close their eyes.
Because they will look surprised.
Correct.
Yes.
Yeah. And they'll have you'll lift them and realise by doing the brow lift that you took too much skin out in the first operation.
I've seen a lot of that on Fifth Avenue.
Yeah.
Yeah, in
exactly.
New York, because of that time of the 1980s.
It's also because sometimes these days even an eyelid surgeon doesn't always offer brow lift surgery, or they can't because they're not trained to do it.
Sure.
So it's not a comprehensive holistic approach. It's a cookie cutter again.
Absolutely.
And that's where we go wrong.
Yes, yes. So in terms of demographic and age, so what's in your practice, who are you seeing the most of?
Well, it depends on the procedure.
Sure.
More facial rejuvenation.
Yes.
I'm seeing probably most people coming through in what we call the sweet spot for facelift surgery, which is sort of 50 to 65, late 40s to 65, 70. I see some 70-year-olds coming through. If they're in good health and we have no other concerns, I think it's a reasonable choice to make. I think you could start to question it over 75.
I agree.
Lengthy procedures. But also those patients don't tend to come for facelifts. If they haven't done it before then, they probably won't be coming anyway.
Sure.
They're very comfortable with their ageing, and that's fine.
The oldest patient I cared for at Dr. Mendelssohn's was 75, and she hadn't told her family, and she didn't really deal with it very well psychologically. I think there was this, pressure, to hide it from the family.
Sure.
And I felt at the time, even though I was in my 20s, perhaps that she was a little bit too old. But you can also have a very, very, healthy and vibrant 75-year-old also.
Absolutely.
Yes.
Absolutely, that's true. I think on that subject of older patients, we're not old, of course.
No, we're not, not yet.
Is that what I am seeing, which is really interesting, back to body dysmorphia.
Yes.
I'm seeing emerging body dysmorphia problems in the older patient, which I never saw before. In rhinoplasty, for example, or facelifts, I'm seeing 55-year-olds, 60-year-olds, 70-year-olds who have traces of body dysmorphia. They're being too hard on themselves, and there's no doubt, I think it's the social media, because they took up a smartphone 5 years ago, 10 years ago, and it's like a baby or a 4-year-old getting an iPad.
Sure.
They're addicted straight away like cocaine.
They are. To Facebook usually.
Correct.
They are.
Yeah.
So do you think that they're comparing themselves all of a sudden?
They're falling into the same traps.
Yeah. Isn't
and
that
it's very
interesting?
sad to see. So, and they may have gone through a separation or a divorce, their confidence is down.
Sure.
It's a perfect combination for emergence of body dysmorphia or traits of it. Perhaps not at the same level we see in a 20-year-old, but it's happening.
So they're all of a sudden very hard on themselves, and they're thinking, well, why don't I look like that?
Correct, yeah.
And then seeking out treatment that's, do you think, often unrealistic?
Yeah, I'm seeing more patients who are unrealistic, which I didn't tend to see in that age group. They were more laid back, they were more accepting of the limitations of surgery, and most still are, but I'm seeing a significant increase. Yeah.
What do you think is the sweet spot for a facelift?
I think 45 to 65.
Sure.
Really under 50, but you've got to drag it down to 45. For some people at 45, can look like 55 based on sun damage, poor lifestyle, stress, those sorts of things. Extreme weight loss, we're seeing more with the weight loss drugs.
Yes.
Those sort of aging effects.
We are too.
And that brings in a whole different range of problems, including muscle atrophy and those sorts of things, which makes it more difficult for the surgery.
I've interviewed, several plastic surgeons in LA, and obviously ahead of us with the weight loss, weight loss drug craze. Obviously, the muscle is wasting. The fat is leaving the face also, as it does in the body, and the skin's getting very saggy. One of the surgeons I interviewed just believes that people get addicted to being skinny, so they don't sort of have a plan, and then there's all of a sudden they've lost the weight, they think, I don't want to put it back on, so they really fall into the trap, almost not being able to see what everyone else is seeing, and everyone else is seeing that they're getting very gaunt and they're looking a lot older, but they don't want to give up the weight loss drug because they love being skinny. So how are we as clinicians, or how are you educating your patients on that sort of area?
Look, I think there's a good way to approach that. I think it probably reflects another form of body dysmorphia triggered, in this case, by weight loss.
Yes.
And their new self, because it is a new self.
Absolutely.
They look completely different.
Yes.
And then they won't really accept the old self. But what you can do is talk to them about the adverse effects, because they're often focused on health aspects, diet and those sorts of things as well. to say that you're probably in a catabolic state, which is not great for anything to do with future aging or health, recovery, if you have an injury, immune system problems. I think if you put it down to health, most people who are reasonably intelligent or highly intelligent will go, you know what, I better turn this around.
Because they start to look very gaunt under the eyes.
They do, yeah.
So, obviously the fat pads, we have, the deep fat pads and the medial fat pads and the more superficial ones. The fat would be, is it descending, or is it just they're losing the fat from the weight loss?
I think it has to be both, because often they're aging as well. The ligaments lax holding the fat pads.
Sure.
But it's probably more a fat loss. And then, you're losing fat that's important for your body, for your immune system. It carries immune benefits. And then it starts to be, the body looks for areas that wouldn't break down normally because it's run out of the other areas. So it goes to other areas, and those areas are areas we shouldn't be breaking down.
It's so difficult for people too, though, because, for an overweight person, they may, their family members or their significant other may have given them a hard time for being too big, and then they've lost it, and then everyone's saying, oh, you look too skinny and you look too gaunt. So, it's very hard for people.
It's an intense psychological battle.
Yes.
It's and those people we've got to be very careful with surgery.
Yes.
Because they're facing the challenge of recovering from surgery. And if they're triggered internally, they're not going to do well with surgical recovery or anything that may go slightly wrong that needs to be fixed. Because people who are in a good place cope with complications that are rare, but they happen. They cope with them well. And it's a beautiful doctor-patient relationship because it's a trust thing.
Sure.
And that trust is not diminished, where it can be eroded if they're not in a good headspace.
Sure.
Yeah.
I want to talk a little bit about stigma, because when I started my career in plastic surgery nursing, family members always had a lot to say about their family members choosing to have plastic surgery.
Sure.
If you have a patient having a rhinoplasty or a facelift, for example, do you coach them or talk to them about how they handle their family members?
Absolutely, and I warn them that those aspects around them, the environment they're coming from, will affect their recovery.
Sure.
Most of them will fall into a state of depression for the first 2 or 3 days because they look strange. I said, you're going to look very rough. You're not going to like me for the first week. You're going to go through this. It's a roller coaster. You'll go through it, I guarantee you. And I'll ask you, is this your depression day today, day 2, 3? And they'll say, yep, you were right. That's way worse if they're coming into it from the guilt put on them by family members.
Absolutely.
And so if I'm sensing that and asking them, why are you doing it? What's stopping you if you're nervous about it? Why are you so nervous? Well, I'm worried about my partner may think. And in fact, I'm going to do it when my partner's away and they won't know. I say, hold on a second. This is a recipe for a disaster. We need your loved ones on board. And maybe it's just a matter of coming with them, talk to me, meet me, and we'll chat about this process and the roller coaster and how it works. And it's not magic, it's surgery, and it has risks. But why not do it if it means a lot to you and it can be done safely? And you've already made good decisions. You've come to someone that you trust, someone has a reputation. You can't get better than that. And from then on, it's up to you to make that last decision. But it has to be done with some sort of support network. You can't do it on your own.
I find husbands very tricky.
Yeah.
We have a lot of women that hide it from their husbands. And I feel, there was a study done in the UK, but personally I feel the men get a bit jealous that their significant other may look better than them or look better than them, and they may be thinking that they could be attracting, another mate.
Of course. Yeah.
So, women come in and there's this bit of a hesitation with a lot of them because a lot of them are hiding it. So again, much better. We love the husbands that come in and they're excited and, they're supportive and, they want to know. They're actually quite intrigued about the process of non-surgical treatments as well. But are you finding that as well?
I think it's a dream if the partner, husband's on board. Honestly, the process is a dream and the patient can see that and they're relieved about that. So involve them. I involve them as much as possible. It's different, for example, for aesthetic breast surgery.
Sure.
And a young patient with a boyfriend, maybe they're pushing their partner to go with big breast implants.
Yes.
that's just it just isn't good.
Sure.
And so I try and separate that on that aspect.
Yes.
But where something is more at a later age in life, where it involves perhaps a high expense for the two of them or the family,
Sure.
then I can see those are also triggers. Maybe it's not just about the jealousy aspect.
No.
I think biologically and evolutionally that's probably ingrained in men or women or vice versa. So that rises to the surface and we can say that's normal. We can manage that. But there are other factors like it's a lot of money.
Yes.
You know, perhaps they're not really comfortable spending that for various reasons. And so those sort of factors come into play as well.
And I think also the other factor is that they are concerned that something may go wrong.
Yeah.
So there's that, that worry or fear.
I think there's that fear that comes from the Hollywood sort of side of things of my partner's going to become addicted to plastic surgery.
Sure.
And I reassure them that I don't think I've ever seen that in my practice.
No.
I think that's a media generated thing.
I do too.
You know, it's like the Jocelyn Wildenstein type thing.
I have a lot of compassion for her. I
Absolutely,
really do, because I spoke about this recently. Her divorce was the highest paying divorce settlement of all time, apparently, or one of them. And she repartnered. Apparently her relationship was awfully sad. She repartnered, met the love of her life, and was seeking out to look like a jaguar or a puma, which, I mean, I don't know who would have signed on to carry out that wish, but
No.
I mean, each to their own. She went on and had a lovely life with him, and they travelled the world and were jumping on and off yachts, but she does get brought up a lot.
Sure.
Yeah.
I mean, the media are just looking for those sort of stories, and they're vicious.
Vicious.
As we all know.
Yes.
So she had no chance.
But this is where I always come back to the beautiful or really well done work is not detectable. You never look at someone who's had great work and say,
No.
oh, it's the volumizing treatment or it's the facelift.
Exactly.
You just say, wow, she's so gorgeous. Yeah. But we always bring back the bad work to overtreated, overdone, bad surgery, or the word botched.
Sure.
So I think that, there's so much good work also, but it just doesn't get recognised.
It's an easy target, right?
Yes.
For the media. They paint with a broad brush.
They do.
Then there's no nuances to the media. And then they do that and they move on to the next story.
They do.
There's no comeback.
No, there isn't.
So,
there's a lot of that clickbait,
Exactly.
fascination.
Yeah.
And there are those patients like her that do want a more extreme look. Have you had any strange requests in your practice?
I mean, I have had some over the years, but I tended to not take them on because I've found that most of those strange requests were associated with significant psychological overlay. And I sensed in those consultations that the patients were in no state to have surgery, weren't going to respond well, and probably we would have had problems. So I don't think there's a lot of it around in Australia.
No.
I think we're fairly conservative still.
We are. We actually are.
Yeah.
I think because we're so far away.
Yeah.
I mean, I love spending time in LA and I've got a lot of friends there, but I love hiking at Runyon Canyon just because the people watching is just so fascinating. Sure. And, even the dogs, some of them are coloured pink and, it's just larger than life over there. So they would be seeing a lot more extreme versions than we do.
I think that's exactly right. I think we're also very good, I don't know why it is, we're very good at sitting back and watching trends and waiting for things to pan out to become clearer. And I always say that trends are exactly that. They come and they go.
They do.
So we can take the best of them and leave the worst and pick things up later. It's like in rhinoplasty using rib grafts now. I really take the patient's own rib. I use the donor rib graft, which is an allograft from a deceased person.
Right.
But that's been going in Europe and the States for 20 years in various forms. We've been able to start using that 5 years ago. A company came to me and asked me to give them advice on how to develop it. I don't have an interest in the company, but it changed my practice because I do so many revision rhinoplasties. They all involve rib grafts.
Yes.
Now we don't have to take the rib from the patient. So, but we, for so many years, didn't have that service in Australia. When we were ready for it, we could look at the data, how you process it, what are the success rates, and pick the best processing rate to give the best outcomes. We had to wait for that though. We didn't go through the trial and error. So we got the best of the best in the end. And I think that's what we do in other trends as well.
There's a brand new injectable coming out derived from human fat.
Okay, yeah, great.
So, and they're drawing that comparison with using bone grafts and, you know, other areas of medicine.
Allografts, yeah.
Yeah, it's called alloclase. So they're going to be using that for hip dips and, you know, décolletage. And so that will be a very interesting space because it will reduce the amount of liposuction needed.
Absolutely.
So there are so many developments and, you know, advancements happening very rapidly of late in the industry. So it is a very exciting time.
Exciting times.
I know it is. Just on that, what is one thing or one misconception that you would, you know, like the public to know about plastic surgery?
I would say that as a fairly experienced aesthetic plastic surgeon now, I like to embrace the idea that we are never going to fully master. It's impossible to arrive at a point where we've mastered this beauty, profession, craft, whatever we want to call it. And I think you always want to see someone who's taking pleasure in pursuing the mastery, accepting they'll never get there. There's never a perfect result. We never know it all. We can never do it all perfectly without complications. But you want to see someone who is really enjoying the process of pursuing that and enjoying drinking from those waters, which is constant self-improvement, a desire and curiosity to learn more from other surgeons, copy other surgeons, just like an art. The best artists learned from masters, copying Rembrandts, spending a year drawing in a studio in Florence, a plaster cast. These days at art schools, they get told, just be original and you'll be successful. So it's forced upon them. That originality, creativity in art and surgery can't be forced. Learn the craft, spend the time, and the rest comes by itself. And so I think you want to see someone who's going on that journey and also regards it as not even work.
I feel like I'm just getting started.
Yeah.
Like, and I do self-fund so much travel to watch other clinicians because I want to get better. And I feel like our job, whether surgical or non-surgical and aesthetics, is such a visual job that you have to watch people that are better than you.
Absolutely.
So that's why I love being overseas and seeing, you know, whether it's London or New York, or I always knock on doors and I always try and get in to see someone. And a lot of people say no.
Yeah, but if you don't ask.
You don't ask, you don't get a seat at the table.
Say yes, right?
Yes.
Okay, and then you can get in there and you can say, well, maybe I won't use their product, but I like what they're doing. Like in surgery, to me, it's not about what they are actually doing. It's what they're aiming for, not so much the route they're going to. But I'm more interested in how their assistant is lifting their hand, how the surgeon moves their hands to get into a particular space. How do they make it look so easy? And I'm taking that and using that tool, and maybe not even doing what they're doing, but we're aiming for the same thing, but we want to do it in a way that's kind of practicing that art and skill for the benefit of our patients. And that's what you learn by doing that, and doing that, chasing that constant improvement, you get this incredible feeling of rejuvenation. It makes us younger.
On that note, thank you, Dr. Andrew Greensmith.
Thank you for having me. Thank you.
Thank you.